This is our quarterly webinar on Parkinson's disease. And today the theme is dyskinesias. And as you know, this webinar is co-organized by three organizations or three entities. It's the Cure Parkinson's Trust, it's the Journal of Parkinson's Disease, and it's Parkinson's Movement. And I'm very glad that we have a really distinguished set of panelists today. And for the next hour, we're going to be discussing every aspect that you can imagine regarding dyskinesias. Before I introduce the panelists to you, I want to say that you are over 100 people distributed over 23 countries. At least that's the countries we saw represented amongst our registrants today. So it's a really international group of people listening in today. And you who are listeners are welcome to interact with us. We have a little chat box, which you can see on the window. I think it's the bottom of your panel, where you can type questions. And if you have questions, we will do our very best to answer them. I may not answer them or have them answered immediately. I will actually ask, or I will cluster them, and then I will ask our panelists to answer those questions, possibly in groups. Who am I? My name is Patrick Brundin. I am at the Van Andel Institute in Grand Rapids, Michigan. And I usually chair these sessions and make sure the questions and discussions flow. And the people who will be doing the discussion today are, first of all, if I have you all introduce yourselves, Angela.
Yes, hello everybody. My name is Angela Cenci. I'm Italian, but I live and work in Sweden. I'm a researcher and I have a keen interest on the mechanisms of levodopa-induced dyskinesia and potential treatments.
Thank you. And Martin, who are you?
Yeah, I guess I'm a patient advocate. I've been diagnosed for 5 years now. Like I personally don't have dyskinesia, but I'm quite close to a few people that do, and I see how it's impacted them. So that's, I guess, what's brought me here today.
And if you didn't guess it already, Martin Taylor lives in Scotland.
Yes, I do.
And Bob, who are you and where are you?
Hi, everybody. I am Bob Hauser. I'm director of the Parkinson's Disease and Movement Disorder Center at the University of South Florida, which is in Tampa, Florida. I'm a clinician and clinical trialist, and my main interest is the development of new therapies for Parkinson's disease and other movement disorders.
Thank you. And we are going to be joined, we hope, by Ray Chaudhry, who's also signed up to be on this panel, but he did text or message us just 20 minutes ago that he is squeezing this into his clinical work and may only be with us for about 30 minutes. And he hasn't been able to sign in yet, but perhaps Ray will pop up in the window any minute now, and he's based in London. So let me kick off with a general question just to kind of set the stage. And I'd like to ask Bob, what is the clinical definition of L-dopa-induced dyskinesia? And are there different types, and what are they called, and what are they characterized by?
Sure. So these are abnormal involuntary movements that are associated with the administration or intake of levodopa. So these are abnormal movements that occur when patients are on levodopa, and we characterize them in several ways. One is where in the levodopa cycle they occur. One is where geographically in the body they occur, and another is what kind of movements we see when the patient exhibits them. So those are the basic ways we look at it.
And can you say, in relation to the intake of L-dopa, what different time windows can these occur in?
Sure. So the most common is so-called peak dose levodopa dyskinesias. And I always teach, if someone just says dyskinesia in the context of Parkinson's disease or levodopa-induced dyskinesia, they're really referring to peak dose dyskinesia since they're so much more common than the other types. So these are typically choreiform, which means dancing or twisting, turning, I like to say. And these generally occur when levodopa is peaking in blood and dopamine is peaking in brain. And they really look like a sensitivity that patients develop over time to levodopa and dopamine. So these generally occur when patients are on, that is, getting benefit with regard to mobility, slowness, walking, and they complicate that on response. Other kinds of dyskinesia are a little bit different. They may occur when patients are turning on. So they may be turning on dyskinesia or turning off dyskinesia. So they may occur at the beginning of the levodopa cycle or at the end of the levodopa cycle. These tend to be a little bit different. They tend to be more dystonic, which is more pulling type. They may tend to occur more in the lower extremities, but it's really the timing that's the big tip-off. And unlike peak dose dyskinesia, which will usually resolve pretty easily or readily when you lower the levodopa dose, these may not be so easy to resolve. And I'll leave it at that for now. Some patients have so-called diphasic dyskinesia, which just means they get it at both ends of the levodopa cycle, both turning on and wearing off.
So it isn't that simple in the sense that, you know, from the outside looking in, one might say, well, it's related to too much L-DOPA, and it only happens when you have the maximum amount of L-DOPA. Oh, I see a new face in our panel here. Welcome, Ray. I have introduced you already, and I know that you have a busy clinical schedule, so thank you for joining us. And you will be with us for about half an hour, right?
Approximately that, till I'm called.
Yes. Okay, so Ray Chaudhary is in London, and Ray is also a clinician, primarily an expert on non-motor symptoms in Parkinson's, but also obviously knows a great deal about dyskinesias and will be part of our discussion today. So Ray, we're working our way through some questions that we already have.
Yeah.
And then we'll be taking questions from our listeners, and there are over 100 people in 23 different countries today.
Excellent.
So I might ask the next question to Angela, because we heard Bob define different types of dyskinesias. And Angela, I'd like to know about how common are dyskinesias? And is there a relationship between how long a patient has been on L-DOPA and the likelihood of having dyskinesias?
Yes.
Or are there other things that govern the risk of developing dyskinesia?
So it is said that in the Parkinson population at large, approximately 30% of people would have dyskinesia, but the prevalence is very different depending on the age group that you consider, depending on how long the person has lived with the disease and how long, of course, the person has been treated with levodopa. So I think I have some figures in front of me, and in a very highly cited study by the Queen Square Neurology Clinic, it was said that in people that have received levodopa therapy for less than 5 years, only 13% have dyskinesias, but after 6 to 9 years, it will be 36%. And in people with more than 10 years of levodopa therapy, almost 100% in this study had some dyskinesia. And the factors that increase the risk of developing dyskinesia are, first of all, the dosage of levodopa. It has been now being recognized that if one manages to keep the levodopa dosage low, meaning not higher than 300 milligram per day, the incidence of dyskinesia remains low. But the problem with this policy is that a person with Parkinson's disease really needs levodopa to move well, I mean, to resolve the Parkinsonian motor feature. So sometimes it's not possible to maintain the levodopa dosage so low. But then this is one risk factor, the dosage of levodopa. The other risk factor is the duration of the disease. And then I can get back to this point when we speak about mechanisms. And the young age of onset is also a risk factor. We can discuss what that means also when we get to the mechanisms. And some studies have described higher incidence of dyskinesia in women or people with low body weight, but that's not confirmed in all studies.
So a pretty complex picture then. It's not, once again, not simple. And clearly there is a relationship between the duration of treatment and the risk.
Yes.
But there are multiple factors that affect the likelihood of getting this.
I would say the duration of the treatment is a reflection also of the duration of the disease. And it seems that it is the duration of the disease is really the most important factor. The duration of the disease and how severe the degeneration of the dopaminergic neurons gets with increased disease duration. So this is, I think, the critical point.
Let me just turn to our listeners again and say that I said previously you can ask us questions at any time through the chat, but there's actually another little thing you can open up in the program. It's called the Q&A, and it's possible there also to type in questions, and we will answer them either live or in writing as we go along. Well, so now we know a little bit about what type of dyskinesias there are, and we know a little bit about how common they are. Angela, do you want to say something about how severe they are? And I'm also going to ask Martin about this, so you be ready, Martin. But
I mean,
you know,
I think that the people who live with this problem are the most entitled people to reply to the question. The estimate of how severe dyskinesia is have been different among different studies. It depends also how you define the burden of dyskinesia, if it is how disabling they are objectively to the movements, if they imply a health risk, like an increased risk of fall, or if they are bothersome to the person who is affected by them in any other way. It could be social embarrassment, it could be impairments in small activities of daily living, like movements that require high precision. And therefore, it's very important that we ask the people themselves to tell, and their caregivers or their nearest friends or family to tell us how much the burden of this problem is to them.
And I got a couple of questions right now on the chat, since I mentioned that this exists. And somebody's asking from Ireland, I believe, Rochelle Flanagan, do genetics affect onset? And I've met several people with young onset Parkinson's with dyskinesia only after 4 to 6 years. And I thought Martin might be very well suited to answer that, as well as when I ask you a little bit about severity. So Martin, you are yourself young onset with Parkinson's. Yeah,
like worth mentioning as well, like I also have a suspected genetic variant of it as well. So that's I've got a Parkin mutation, which is also like I believe associated with increased risk of dyskinesia. So like yeah, like I'm lucky that I've avoided it so far, but like yeah, maybe something I encounter in the future. I think it's yeah. Well, can you just go over the question again, Patrick, just so I know what I'm answering?
So how troubling are dyskinesias? And if you now speak not just for yourself, but you speak for the whole community as an advocate, how troubling are dyskinesias to people affected by Parkinson's?
I think it's like you know, particularly amongst the young onset community, it's one of the things that people fear most. Like it's quite it plays a large part in the decision as to whether to start levodopa or not. I think a lot of people go under-medicated for a long time with the hope of avoiding it. You know, just this week I spoke to someone who's getting by on just Risadrilene, partly through fear of what the side effects of taking levodopa are. I think that also, like amongst clinical neurologists, there's still a school of thought that like they should know about levodopa for that reason as well. Like and yeah, like as I mentioned before, my friend David Sangster, who's like is a great advocate and has made a lot of videos about this. Worth looking up on YouTube.
He actually just commented. Did you see that? So David Sangster just said, "I can comment on severity. I'd be happy to." And maybe you can't see that little box, but it came in the Q&A field. So perhaps we can have somebody from the Cure Parkinson's Trust post a web link to David Sangster's blog and his video. It would be helpful, I think.
Yeah, I think, I mean, that's for anyone watching who doesn't understand how much of an impact this can have on someone. I think David documented it really effectively in his video diaries about how it was impacting him. And like, he, I think latterly wasn't getting any, very, very brief on time when he was functional. And like, you was either it was going between like essentially rigid and like full blown, really quite disabling dyskinesia. And he very bravely documented all that on video. I think just to recap, I think it's the thing I'm scared of, because I think it's like I would find it very socially isolating. I'm quite fortunate that I'm quite mild symptomatically. Like I've been able so far to an extent to hide my condition. Like I think that's when you come out. You know, when you got that, that's when you're unable to just blend in with society, and that's I imagine that's quite isolating, quite embarrassing, and quite exceptionally difficult to live with.
So you would say it's something that is a source of fear, but it's potentially, for those who are severely affected, it's really troubling, as I understand it.
Yeah, I've been in the company of people that have had quite severe dyskinesia as well. I don't know how to live with it. Personally, I think it's they're such brave people to do that, because it's scary. It's something that you desperately hope to avoid with your chosen management strategy. I think Angela mentioned, for example, earlier on, the dose, keeping it to 3 times 100 is one of the ways you can potentially look to avoid it. I'm 5 years and I take 450 a day, so that's that immediately makes me think I'm 50% above the risk level already. So yeah, that's again, it plays into my fears, and I think it's it's the one thing I'm personally very frightened of, because I think it be very socially isolating and quite a difficult thing to live with.
So I should thank David Sangster, whom you mentioned. He's just now sent us a link to a video which he has made, and I've distributed this in the chat so everybody can see that. So no doubt that this is a troubling side effect of L-DOPA therapy, and it's pretty commonly occurring, clearly. But on the other hand, I understand also that over the last 30 years or so, the likelihood for a patient to develop dyskinesia might be slightly lower than it used to be 30, 40 years ago. And Ray, you've written an essay or a paper, a scientific paper on this recently. Ray, do you want to comment on this?
Thank you. I think, firstly, it's important to point out that the severity of dyskinesia is a very personal thing. As Angela mentioned, in some patients, or people with Parkinson's, we see very severe dyskinesia with immense societal impact and isolation, as also has been mentioned. I think there are two things to remember, that over the years, as you said, Patrick, that we've developed long-acting therapies, we've developed continuous drug delivery, we've developed levodopa-sparing strategies, we've now developed deep brain stimulation. And to say that the dyskinesia prevalence is rising means none of these therapies have been successful. So what we are seeing is that there's been a dramatic reduction, and you see this from papers and data from all over, of troublesome dyskinesia as defined by something that really impacts on patients' quality of life, and also not the caregiver, but the person's quality of life. And also the other impacts that goes with it. And that's borne out by data, and we've provided the data in the viewpoint, and subsequently it's been again echoed by 2 large studies, one from Brazil and another one from the UK. And the other point to make is that this does not mean individual dyskinesia is not severe. Of course it can be severe, but the troublesome dyskinesia we see in my clinical practice, and I look after over 1,000 patients, it's really, really uncommon. That's perhaps because we use more effective dopa-sparing strategies, we have deep brain stimulation, all of these are working, and continuous drug delivery, very commonly used in the UK, apomorphine, levodopa infusion, which both have very good anti-dyskinetic action. And the other point to remember is that 2 dyskinesia trials failed to recruit people to their levels of dyskinesia because they could not find such patients, even though they had a multi-center design. So the point is that I think troublesome dyskinesia is probably a lot lesser than we thought it could be, certainly in the early 2000s. A lot of the dyskinesia prevalence paper that's quoted now dates back to the late 90s and early 2000s, when the situation was quite different. And the second thing, the PD Med study also shows that in fact, although we go on about dopa sparing strategies, after 5 years, whatever dopa-sparing strategies you use, the dyskinesia rates were similar. And again, they found very low rates.
Could you just explain what that means, Ray, for the people who are not into that term, the dopa-sparing strategy?
So if you use, like even I personally use it, if I would see a person with a relatively young onset Parkinson, now that again is I'm not being ageist. I see people who are in their 60s who consider themselves as young, which is fine because they're biologically healthy and they have healthy aging. It depends on the person's lifestyle. And Parkinson's need to be personalized. We should not be driven by specific guideline-based diktats. So I would use it in the form that I would ask a person that if I give you levodopa, you might develop these movements, these kinetic movements. And there is an option you can avoid levodopa. You can use other treatment like rasagiline or monoamine oxidase B inhibitors or dopamine agonists, which might give you lesser chance of dyskinesia, but the treatment clinical effect may not be that pronounced. So in that scenario, those particular drugs are avoiding early use of levodopa, and therefore some people would call them dopa sparing.
So we had a question actually, again from Ireland. Somebody says, my neurologist said if I stayed under 300 milligrams of L-dopa per day, it reduces risk of developing dyskinesia. Is this true?
I think that's broadly true. And again, we would probably go back to the L-dopa trial of Stan Farn, which was the only placebo-controlled levodopa study there is. And clearly that showed once you hit this 450 milligram dose and above, your dyskinesia rates and the wearing off rates rise substantially, even at 9 months to a year. So in my own clinical practice, I would very much think that's a reasonable assumption. After 300 milligrams, if you want to increase the dose further, you have other options. You can use a COMT inhibition, you can use monoamine oxidase B inhibitors, or you can use other forms of therapy to adjunct your treatment. But you keep your levodopa dose down, relatively down, at the same time get a good effect. It's a pretty good strategy.
So if I were to summarize, Ray, you are saying that if one with therapies, one is able to take the right tablets, take slightly less of some of the medications, today the likelihood of developing dyskinesia, and particularly very troublesome dyskinesias, is lower than it used to be. That's the sort of take-home message.
I think absolutely right, Patrick. You absolutely put it right. If we are careful, if we take into account the enormous advances we've made in the last 30 years of research in this area, clearly dyskinesia remains a problem. But troublesome dyskinesia that intrudes in your day-to-day activities and your ADL, if you use your treatment wisely, or if you are given treatment in a wise manner, and not just treatment, there's several other factors, perhaps body weight, I think is an important issue, low body weight being a dyskinesogenic trigger, and personality. If we take into all of these factors into account, if we use the modern treatment strategies that we already have, if we judiciously use levodopa, as has been pointed out, 300 to 400 milligrams sort of ceiling, I think the chances of troublesome dyskinesia are very low indeed.
So I know with your paper, which was entitled, Should There Be Less Emphasis on L-Dopa-Induced Dyskinesia in Parkinson's Disease? Paper came out recently, caused a bit of a debate and discussion, and not everybody agrees. I'm going to ask you, Bob, do you agree in general with what Ray says, or do you have a slightly different opinion?
Well, I agree with one part and disagree with a lot of the other parts. I do agree with Ray that we're seeing a lower prevalence of dyskinesia and we're seeing less disabling dyskinesia. But I think we have to, first of all, be careful about our terms. There's still a lot of unwanted dyskinesia, and I think Martin sort of talked about some of that. There's the social isolation, and we see that in tardive dyskinesia, which is a totally different disease that I've had a chance to look at, and we see those similarities. So I like to think about unwanted dyskinesia, then there's troublesome dyskinesia, then there's disabling dyskinesia, etc. So we need to be careful when we look at scores and what the reports are, that we're not throwing out all the unwanted dyskinesia. There's still this unmet need. So that's point number one.
Could I just ask you, you used the word troublesome. I just got a question again, actually, from David Sangster saying, what is troublesome?
Well, you're talking to the person who coined the term. We created it for the diary, and the term troublesome dyskinesia is dyskinesia that interferes with function or causes meaningful discomfort. So that's what it means for the purposes of the diary. And there's been a lot of confusion because people will sort of throw disabling and troublesome around similarly, and they're not really, I don't think, the same in my book. Disabling sounds like there's a greater interference with function. And if you look at some of the MDS, UPDRS scoring, where 1 means interfering with some activities, generally when you look at the prevalence of dyskinesia compared to what portion of those with dyskinesia report some interference with activities, it's about 50%. So if we say 40% have dyskinesia, if you look across the population, somewhere around there, about 50% of those, or 20%, will report some interference with function. And that, again, doesn't even include those who will say, well, it doesn't interfere with function, but I sure would like to get rid of it if I could. But I want to go further, and here's the most important point in my book. When we see a person who has some slowness and small movement, bradykinesia, and they have a little bit of dyskinesia, it's that dyskinesia that prevents us from saying, well, let's get you better treated. Let's give you more levodopa, more dopaminergic medication, because we know they'll exhibit greater dyskinesia. So that dyskinesia represents a ceiling in our ability to provide greater treatment. If we had a great treatment for the dyskinesia, we'd be open to better treat the slowness, the stiffness, the tremor, etc. In addition, although I agree with what everyone said about there's less dyskinesia, I think it is because of 2 things. Number 1, we're using lower levodopa doses, and because of the introduction and widespread use of DBS. But my question is, how much are we paying in terms of Parkinsonism, bradykinesia, slowness, stiffness, tremor, when we have it in our minds that we want to use 300 milligrams as long as we can, 400 milligrams as long as we can? I think our patients may be paying the price in a way that we don't recognize and they don't recognize by trying to keep that levodopa dose down. And again, if we had a great, highly tolerable drug for dyskinesia that did a great job, we'd be liberated to use levodopa much more freely and treat bradykinesia and other symptoms of Parkinsonism a lot better than we do now.
We had a question related to specifically this. It was for people who feel they're not able to limit their L-dopa dose to maintain a reasonable function. Are there other ways of minimizing the risk for L-dopa-induced dyskinesia development?
Yeah, well, I'll give it a stab. There aren't really well-established ways known to do that. My personal philosophy is we treat patients to the point where they have acceptable function. There are studies that show if a person's on a certain amount of levodopa and they need more, when you add a dopamine agonist, you do get less development of dyskinesia compared to just going with more levodopa. Of course, you pay for that potentially in getting less bradykinesia and Parkinsonism benefit, and there are more side effects associated with dopamine agonists, including sleepiness, potentially nausea, hypotension, hallucinations, etc. So it's not a great solution. Amantadine is another drug we'll get into. Amantadine is another anti-Parkinsonian medication. It can be used to treat dyskinesia. In the situation you just talked about, it can provide benefit and maybe either prevent the development of dyskinesia and provide Parkinsonian benefits. So there are some options, but I'll say they're mildly helpful options.
So some agreement with Ray regarding that in the last 30 years there's been progress, but you still think dyskinesias are a significant medical issue. And I've heard a question here, when I have severe dyskinesia, it leaves me very tired. And I'd like to ask, well, Bob, and maybe I have Martin fill in here, secondary effects of dyskinesias, like, I think you touched upon this, Martin, social isolation and the fact that you can have fatigue as a consequence of dyskinesia. Maybe you want to start off on this, Martin. I think it's a good question for you.
Yeah, I think just a few things levodopa is a great drug. Like when it works, it really effectively treats symptoms. I mean, look at me; these are both hands, quite the thing. When I'm off, I can't move that hand all that well. So that's like shows you how effective it can be as a treatment. If we were to come up with a way to you remove that side effect, the dyskinesia, it means people can take as much as they need to get, a level of function that allows them to be, functional members of society, to keep them working, to like keep them being good husbands, dads, wives, sisters, whatever. So I think, I do get that, like, we now know more about management strategies and how to potentially treat a patient to avoid that. Like I recently, for example, when I had my review earlier on this year for medication, I chose to add entacapone to my dose rather than taking any more Cinemet, because I felt that was like, that increases the efficiency of the existing Cinemet you're taking. But I think management strategies are not consistently applied. So like, we still get, I still hear, my information is all anecdotal, so from speaking to people in the community, you get people that are told to stay off drugs altogether for as long as they can, people that are told to just take proton antagonists and stay on that as long as they can. So there's still like a culture, I think, of levodopa-phobia in clinical neurology in some spheres. So I think if the research is not to find a pharmaceutical solution for dyskinesia, it's perhaps to get good data out there to say, we've got this drug, it's a very effective symptomatic treatment. If you apply a management strategy in this way to your patient, they will have a good quality of life and they will hopefully avoid dyskinesia. But I think that is not necessarily consistently applied in clinical neurology. I think there's a lot of inconsistency in how that's how patients are like advised as to to what medications to take.
So better information to those who are actually managing patients in terms of avoiding L-dopa is, I think, what you're asking for.
Yeah, I think it's like a lot of the evidence now is pointing to the fact that like dyskinesia is not necessarily caused by levodopa itself, but more like the progression of the disease. And like, though there's inconsistency with that as there is with everything with Parkinson's, but like, I think with that in mind, we need to try and remove that fear of the drug, because it still is the most effective treatment we've got.
Mm. And
like, it's say I met someone recently who's avoiding it for fear of the side effects, and like they're quite visibly stiff and slow, and that's all come about because of the fear of the side effects. So I think we just need to get to a stage whereby we remove that fear, and if it's not necessarily to have a drug that treats dyskinesia, if it's like through getting that management strategy out there so it's consistently applied and to patients.
So thank you. I should say that we're moving into the second half of our webinar, and we've had an unprecedented number of questions. They're coming in both for, so if you ever see my face, I'll be cross-eyed looking at two different computer windows at the same time. And we're not going to be able to answer all of these questions today, but we will try our best to answer them by email or in some kind of blog that will follow this webinar. And we have a few topics that I want us to cover during the last half hour. So I'll be inserting some of your questions, but as I said, some will have to come after the webinar.
I just pick up a quick point, Patrick.
Yes.
Just like on Ray mentioned about weight. That's an observation I've noticed myself. Is like people, it may be a chicken and egg scenario, but like from what I've observed, like in the community, people that are quite thin tend to be more prone to like dyskinesia, and like I don't know if that's perhaps through the absorption and if they've got more fat to absorb it or whatever, or it's less get up to brain or whatever. Mm. Like I made this point to my neurologist recently. Like I'm quite broad, like I'm tall, so like should I be taking the same dose as a wee 5-foot granny that's just been diagnosed that's nothing over? But I think
so that's a specific question to Ray, and Ray had actually raised his hand here on the saying he would also want to respond to some of the points Bob raised. So maybe you could do two things, Ray. Answer Martin's question first about body weight and dyskinesia risk, and then come back to some of the things that Bob talked about 5 minutes ago.
Okay, I'll try and be brief. So firstly, in response to Martin, in my practice, and again, it's by no means a consensus, if somebody has low body weight, I'd be careful. I am usually careful about the levodopa dosing. Try and stick to 300, 450 maximum ceiling and use other sparing strategies as much as possible. The mechanism is not entirely clear. Angela might have more information on that, but clearly there is a subtype. We have endophenotyping Parkinson's using motor and non-motor markers. That seems to be a very specific group, often associated with reduced sense of smell, hyposmia. So it might be something to do with the olfactory, limbic pathways. I'm not really sure, but clinically, I think I'm just a bit careful in that particular group because it's where the low body weight might indicate that status to be a risk factor for generation or for dyskinesia in future. So I'm just careful about the levodopa dosing there. So partly probably answers Martin's question. I think I just wanted to respond also to Bob in relation to the fact he mentioned that he's searching for an ideal drug that will develop and that will stop dyskinesia so that we don't have to be worried about a levodopa dosing. My comment to that is that, yes, we've been searching for it for about 35 years. In the meantime, if you look at patients and patients what they want, there is a wonderful paper, not just one, several, which have listed the top 10 bothersome symptoms to patients. They're not dyskinesia. The top is wearing off and fluctuating response to medication. 7 out of the top 10 that people with Parkinson's are telling us are non-motor, dribbling of saliva, fatigue, pain, sleep, urinary dysfunction, constipation, memory problems, apathy. We don't have a single proper randomized control trial in any of these in the last 30 to 35 years. Whereas with dyskinesia, industry and charity have spent millions and millions, and we can manage it effectively. Maybe not ideally, but effectively. But I think it's a real issue. Many of my patients who have dyskinesia are properly controlled, but they can't socialize because they're dribbling saliva. They can't socialize because they're severely constipated. They can't socialize because they're constantly in pain. They can't socialize because their memories are not working as well. They can't socialize because their mood is gone. We need to do something about this, not just carry on the same tunnel vision dyskinesia approach. That was really my point. It's not at all to say that dyskinesia is not a problem. Of course it's a problem. But it's a problem that we can manage effectively with judicious use of clinical practice. However, in these other things I've mentioned, we don't have level 1 evidence in any of that. And in 2019, I regard that as a real problem.
So could I maybe make a comment there? I think you're making a valid comment, Ray. On the other hand, for all those non-motor symptoms that you listed, there are very few animal models that can mimic them, and it's hard to know exactly how to take a new therapy, a new drug into clinic because we don't know the underlying mechanisms for them. And why is the drug industry so interested in dyskinesias? It's a very tangible, easy thing to study, and studies can be conducted over a few weeks instead of several years, which disease-modifying therapies require years of following patients. Here it's a shorter time window. I'm not saying that decisions should be made entirely based on that, but I think it's part of the world and reality. Bob?
I just also want to point out, I'm not saying we should study dyskinesia and forget about all these others. Of course, we want treatments for all these others. I'm saying we still need to apply ourselves and get better treatments for dyskinesia. And one point that you made, you said patients still have difficulty with wearing off episodes. And part of my point is if we had better treatments for dyskinesia, it'd be easier for us to treat off episodes.
And I got a comment once again from Ireland. We have a very active person in Ireland saying young onset Parkinson's disease would rate dyskinesias high in symptoms. Actually, there's a question mark there, but I think that question mark could potentially be an exclamation mark. For people with young onset Parkinson's, dyskinesias can be a huge issue. And I got another question from an individual whom I also know has Parkinson's young onset asking, is there anything, for lack of a better term, that could be called dyskinesia-induced cognitive impairment? That's an interesting question. Is it dyskinesia just affecting movement, or do dyskinesias affect cognition? I don't know the answer to that. Does anybody know?
I think many of us know, but to whom do you want to address the question?
You go ahead, Angela, since you spoke.
Yes, so Ray knows this very well because he is an expert on the non-motor features of Parkinson's disease. People affected by dyskinesia also have non-motor correlates of the problem, such as accelerated thinking, euphoria, increased sweating, and it has been described that perhaps a sense of judgment during peak dose dyskinesia could be slightly impaired. So, I mean, certain cognitive function could be affected.
So that's a good answer. So we have 20 minutes to go, and I'll just let everybody know what I'm hoping that we can cover during this time. I'd like us to discuss if there are good animal models of dyskinesia. I hinted maybe there are, and I want to discuss what might be some of the cellular and molecular mechanisms that contribute to dyskinesia. This is a bit of a mystery, of course, but a lot of things are known, but we don't fully understand it. And then if there are future research directions regarding dyskinesias and ways that in the future maybe we'll be able to treat them.
Can I just briefly come in, Patrick, on
Yes, go on, Martin.
the cognitive thing? This is where we perhaps need to think about things more holistically. I had a physio assessment recently, and my cognition's still pretty good. Like, I think I'm pretty sharp. I hope that comes across. But yeah,
I think it does.
I had a physio assessment recently where the physio had me walking up and down the stairs reciting firstly types of food, then animals. Like, what was notable? Well, I walked up and down the stairs first without reciting anything, and she measured the time to do that, and it was quicker. And then when I had to try and think of different animals or whatever, I think what was clear from that is because when you're having to think and move at the same time, it was slower. I think it stands to reason that if someone's got severe dyskinesia and their movements are uncontrolled, their cognition will be affected. I don't think there's any doubt about that in my mind as well. So I think that's when you're moving about all over the place and you can't control your movement, your thoughts are not going to be as clear and as focused as they otherwise might be. So I think that's definitely a thing as far as I'm concerned.
It's a great comment. All right, let's move to this idea of understanding the cellular and molecular mechanisms and using animal models. And Angela, you're a world-renowned expert in this area. Tell us what kind of animal models exist and what have we learned from studying these animal models and in conjunction when studying the brains of people with dyskinesias?
Well, first of all, it's one of the reasons why the pharmaceutical companies are interested in dyskinesia is because the translational path from the animal studies to the clinical trials is very straightforward and very well established, which means we have very well-validated animal models of at least peak dose dyskinesia, which is the most common variant. What we've learned from these models is a lot, but let's start from the first point. I think we've learned that the extent of denervation of the motor part of the striatum is really essential for the occurrence of abnormal involuntary movements on levodopa.
Sorry for interrupting, Angela. Yeah. Just for the audience, so obviously in a mouse or a rat, you don't have to treat that mouse or rat for years before these dyskinesias appear. Just give people an idea of what it looks like.
So what we do is that instead of waiting years for the animal to develop severe nigrostriatal dopaminergic degeneration, we induce it using a toxin that kills dopamine neurons, and this is the same principle is applied to rodents as to monkeys. And then we are therefore mimicking a rather advanced stage of Parkinson's disease, let's say a state that is someone who would be more than 5 or 6 years into the disease, more than 5-6 years after the diagnosis. And then we treat the animals instead of, giving low dose fractionating very slowly. We try to make life easier for us. So we give a full dose of levodopa from the first day. I mean, we also can make it slower, but I mean, it has never been an advantage to us. So we try to save time, and we give full dose of levodopa divided into 1 or 2 administration per day. And the animals treated this way will develop dyskinesias pretty rapidly. Not all of them, of course. We and others are also investigating in animals why certain subjects are more susceptible to developing dyskinesia than others. And this is also a very interesting topic. Some are looking at the genetics of the animals. I have been looking at the state of integrity of the serotonergic system, for example, and found that the animals with a larger susceptibility to dyskinesia have a larger serotonergic innervation to the motor part of the striatum, and which is something that has been seen in patients too in certain studies. So the ratio between the density of serotonergic innervation versus dopaminergic innervation in the putamen is a risk factor for levodopa-induced dyskinesia, meaning that if you had very little serotonergic innervation in the motor part of the striatum, you would be relatively protected from dyskinesia, at least with the normal dosage of levodopa.
So does that mean for those, I'm sure many of our listeners have at one point in time been on antidepressants that act on serotonergic neurons.
Yes.
Do antidepressants affect the risk of developing dyskinesias?
This is something that is debated, and a dedicated study has not been done. There are studies indicating, however, retrospective studies, that people who have taken antidepressants have had a later onset of dyskinesia. So they started to develop dyskinesias later during the disease. And certain smaller studies have found that fluoxetine, there is one study I know about, fluoxetine had improved the severity of dyskinesia, but these are anecdotal reports, and a dedicated study has not been done. So this is one risk factor. I think we have to consider dyskinesia as a complex phenomenon with a complex pathophysiology, meaning that several contributing factors are interacting with each other. And this is also something that we have learned from the animal models. And personally, I think that the changes occurring in the neurons that should respond to the treatment, so the neurons in the striatum that bear the dopamine receptors, these
so it's
neurons
not the amount of dopamine itself it's
a combination. It's a combination. Is the amount of dopamine that gets into the brain, the way in which it is released in the brain. So for example, both in animal models and in patient studies, it has been seen that subjects affected by peak dose dyskinesia have some abrupt peaks of dopamine release in the striatum shortly after the intake of levodopa. So this is one factor, but then we also have seen that what happens with the severe loss of dopaminergic fibers in the striatum is that the neurons that should respond to the treatment, the striatal neurons, the neurons that have the dopamine receptors, undergo profound structural and functional changes. And under these circumstances, in animals, we can induce dyskinesias also bypassing levodopa totally and just giving substances that stimulate the dopamine receptors, particularly the D1 receptor. So this is another layer in the cascade of events that lead to dyskinesia that one should always consider.
But you said profound structural and functional changes
Yes.
in the striatal neurons. So do you think these are permanent changes, or are these plastic changes that might be possible to reverse and correct?
I think that in the animals, we can reverse them or prevent them for sure. And we have done a study actually where one of the most profound changes, that is an atrophy of the dendrites of striatal neurons, can be reversed with chronic levodopa treatment in some of the neurons, not in all. So that's very good news. Then whether this would be possible to achieve in the patients, I don't know. We wouldn't know. But we can certainly prevent these changes.
I just got a message from Ray that he is being called to the clinic. So Ray, you may have to leave in any second. Do you want to add anything to this discussion? I know, Ray, your primary research is not on molecular mechanisms of dyskinesias, but is there anything you would like to add to that?
I think I'd just like to say what Angela said, and a very good question was asked about fluctuations that also occur with motor fluctuations. So it's very important to remember that many of our patients, when they're dyskinetic or they're off, they really feel quite unwell, not just because of the dyskinesia, but of the non-motor symptoms that happen with it, which are cognitive. So clouding of the mind is classically described. I have several patients of mine telling me that their thought process becomes slowed or a little bit clouded, and some people get pain and some people get a lot of sweating, which can also be really a real problem. So again, in some ways, better control of these symptoms as a whole it will have secondary effects and benefits. And in relation to the animal model work that you said, Patrick, I think the positive thing I would say is that there is no development of some non-motor animal models. You will know very well about this. And it's really to be applauded that in the last 3 to 4 years, we have at least 5 or 6 major clinical trials which have started, which are specifically addressing sleepiness in Parkinson's, pain in Parkinson, and more recently urinary function, and of course cognition and depression. So I think that's really a positive move that this is happening in parallel with developments that we are seeing in the motor aspects, particularly with dyskinesias and other treatments, other aspects of motor dysfunction that are being addressed.
So maybe the overriding statement would be, just as Bob said, I think we need research on non-motor symptoms, no doubt, but it doesn't exclude L-dopa-induced dyskinesia research either. So both are needed.
Absolutely.
And,
actually, can I come in with a comment here?
Yeah. Yes. Go ahead, Angela.
If we consider the basic science funding agencies, it is more likely to get funding to study non-motor symptoms of Parkinson's disease than to get funded to study dyskinesia. So the perception that there is such an emphasis on dyskinesias in Parkinson's disease perhaps is raised perception by interacting with the pharmaceutical companies. It is certainly not the perception of basic researchers who are interested in dyskinesia and want to make progress in this field, because sometimes we have big troubles being funded.
So I see your point.
Because of the statements that circulate, it's not a problem anymore. It's less common, and so I think so. This is my way of seeing the situation.
So that's a good way to segue onto the last topic. I think, what do we hope from the future in terms of new ways to, number one, prevent that dyskinesias ever occur, and number two, to stop them or reverse them once they've occurred, even at the structural plasticity functional level. And are there new things out there? We know that deep brain stimulation is useful in some conditions, but tell us, what do you think is coming up? And I'm going to let anybody who wants to put their hand up. Ray just left, so bye, Ray. But Bob and Martin put his hand up. So Angela, you start, and then we'll have Martin and then Bob.
So I think that we have many possibilities, many avenues to pursue. Of course, my personal interest would be to prevent the dyskinesia from happening in the first place, but then the study of dyskinesia gets intertwined with the study of disease-modifying therapies, and this is something we can address in animals. We also know that there are several non-dopaminergic systems that are altered during the progression of Parkinson's disease, and that play a major role in the development of levodopa-induced dyskinesia. And there are many receptor targets related to, for example, the glutamate system, or I'm very interested in the glutamate system, but also now the cholinergic system, the serotonergic system, that if we keep on trying, we may find eventually the perfect target and the perfect ligand that is safe to administer to patients, and that can be given together with levodopa and just take away the dyskinesias without interfering with the good action of levodopa. So I stop here, and then I'd like to hear Bob view on that.
So Martin, your fellow advocate David Sangster has typed here, number one, better education from day one. Number two, better guidance. Maybe those are the lowest hanging fruit in ways of reducing suffering from dyskinesia.
Yeah, I think that's obvious. As I say, clinical neurology is it's probably the smartest people we have in medical profession going to that. So I think we're not. There's definitely inconsistency in how they approach people and how they apply treatment methods and what the knowledge of what the potential side effects are and like the costs and benefits and all that kind of stuff. Then we need to get more data out there as to fully build up an understanding of what the picture is, and then we get more consistency in clinical practice. Because that's one way you can potentially look to mitigate and avoid dyskinesia through better understanding of how to apply the treatments we have already. I do think, I think Bob made the point earlier on, it's a valid point as well, if we do have a pharmacological solution to dyskinesia that works well, we can then give people as much levodopa as they need. And that, given it is a very effective treatment when it's working well, could potentially change the landscape quite significantly as well.
So Bob, I'm going to put you on the spot when I ask you here about research and developments for the future by saying, do you remember the study that came out recently stating that certain gut bacteria can actually metabolize L-DOPA? Do you see that there is a new avenue for improving L-DOPA therapy by using the gut microbiome, preventing that it causes fluctuations, or using it to reduce fluctuations and improving delivery?
Well, I think you've just thrown a curveball in with regard to the pulsatile nature of levodopa. There's a lot of information that the pulsatile nature of levodopa is part of what brings on dyskinesia. And this gets back to the so-called continuous dopaminergic stimulation hypothesis, which is if we can really deliver levodopa in a nice continuous fashion, maybe we won't develop as much, or patients won't develop as much dyskinesia. And there's pretty good evidence on the backside of this. Patients who have established dyskinesia, when they get an infusion in the gut with a medication like Duopa, which is levodopa infused into the gut, you can see their dyskinesia reduce over time. And surprisingly, it's not because their levodopa is threading the needle between high and low. Their levodopa levels in the blood are actually quite high. And so this is called, or I call it depriming. They acclimate to these high and stable levels, and it sort of undoes the dyskinesia sensitivity from the pulsatile delivery of levodopa. So I think what you mentioned is kind of along those lines, I think, getting into a more pharmacokinetically stable delivery of levodopa. So what we really need to get into that more realistically is long-acting, easy-to-give levodopa formulations from the beginning. We don't really quite have those yet. There's some long-acting levodopa formulations in development that maybe will be good enough to really test that hypothesis. When we discuss it in clinical trial circles, there is concern that it'll take a number of years from the beginning of the introduction of levodopa to do those trials. So pharma is a little bit concerned about that, but I think we will see them one day.
Yeah, so we actually did have a question about gut malabsorption from Ireland, Rochelle Flanagan. Rochelle, I don't know if you know, we have a pub called the Flanagans just down the road here in Grand Rapids, but your question was malabsorption. So we know that there is, it's called gut dysbiosis in Parkinson's with changes in the microbiome. And is that one way to help also? Not now, this is getting into details, but not just changing the metabolism of by the bacteria. What do you think, Bob? We have 30 seconds to go approximately.
Well, I don't know. Generally,
it's an unexplored area, I think is fair to say.
Generally, we're thinking about trying to improve levodopa absorption to treat off, and certainly patients who have Helicobacter, we can do that. On the other hand, it's the same old story. However you increase levodopa delivery, patients who already have a threshold to exhibit dyskinesia, if you improve levodopa delivery, they'll get more dyskinesia. So I'm not sure that we really have a handle on how the gut can help us avoid or treat dyskinesia at this stage.
That is a great way to end our webinar. And I'd like to thank all our panelists, Angela, Martin, Bob, and then Ray, who had to leave to see a patient. I think you've had a great discussion. I've learned a lot, and I hope the listeners have also learned a lot. And we'll try to answer all the questions that we were unable to address. We had a ton. And we'll put them either in a blog form or somewhere on the web. Cure Parkinson's Trust and Parkinson's Movement will help us with that. And we hope to see you again in about 3 months from now with a new exciting topic. Who knows what that will be. Thank you so much, everybody. And bye-bye.
Thank you. Bye-bye. Thank you. Bye-bye.
Thanks, Patrick.
Thank you, Martin. Bye, Angela. Bye, Bob.
Bye-bye now.